Welcome to the second of the GIC's annual public information sessions for 2022. Thank you for joining us, everyone. We are looking forward to sharing some important information with you about this year's annual enrollment, the upcoming procurement of health insurance carriers, as well as some other useful information and resources for you all. We do, as you can see, have ASL services here today. We also have CART services available for this session, and a link has been posted in the chat function for access to those services. We are also recording these information sessions, which will be available to anyone on the GIC's YouTube channel. So to start, I'd like to review the agenda. Is that slide up? So first, we'd like to review some of the basics about the GIC as a refresh for longtime members and an introduction for any new members who have joined us. We will then move on to health insurance premium rates, where we'll explain our process a little bit and our timeline for developing those rates for the upcoming year, and say a bit about what we anticipate those rates will look like. Next, we'll discuss the one proposed change to our health insurance plan design for the coming year and transition from there to reviewing the upcoming procurement. The presentation portion will wrap up with an overview of retirement and Medicare issues from GIC's Director of Operations, as we often get those inquiries during this session. So our Director of Operations, Paul Murphy, will be here and present at that time. So that's the agenda for today. If we move on to the next slide. So we hope that these sessions will be, as they were last year, very interactive in nature. So if you have questions throughout the presentation, you may submit them at any time via the Zoom Q&A function. So not the chat function, but the Q&A function. We have members of GIC staff on hand to answer some of those questions directly in writing in real time. Again, also through the Q&A function. We will pull out some questions that we think will be of general interest and answer them after the presentation in the sort of live verbal section of the Q&A. So if you have a question, I do want to note this, if you have a question that is personal or specific in nature around your benefits, please utilize the contact form that's noted in the yellow box at the bottom of this slide, and a member of GIC staff will follow up with you directly after the information session. So we won't be responding to those kinds of inquiries here today, as we want to maintain your privacy. So before we jump into the GIC overview, I want to note at the outset the dates of this year's annual enrollment, as these dates are the context for much of what we will discuss here today. So the annual enrollment this year will open on April 6th and close on May 4th. So please plan accordingly for that. And now I'll move on to a GIC overview. So just a high-level understanding of the GIC. Some of this will look familiar to many of you. So first, I want to start, as we always do, with GIC's mission, which is to provide its members high quality and affordable benefits while driving improved health for our members and higher value care delivery across the Commonwealth. So we've bolded here both members and high quality affordable benefits, because that's the core of us delivering on that mission. So as many of you know, the GIC aims to meet this mission through its variety of coverage options, a wide array of those options, including healthcare, dental and vision, life insurance, and long-term disability insurance, along with our EAP program. So we have a wide variety of benefits that we offer. So the next slide will note our current health insurance carriers. That's what we will be discussing most here today, and pharmacy benefit managers. Not shown in this slide are the carriers for our other benefits, such as MetLife for dental, Davis Vision, and benefit strategies that runs our flexible spending account. So these are the current partners with which we work. So here I want to just highlight a couple of quick data points about the GIC, including our over 460,000 members and the makeup of our 17-member independent commission. You'll see that they represent a wide array of backgrounds and perspectives, and they really guide the strategic work of the agency, working with me and the rest of the staff. The green box highlights our annual budget. The vast majority of that budget, of course, are our members' insurance claims. We have a very small but mighty staff to manage a very large budget. On the next slide, I just want to say a word or two about the GIC's budget. And in particular, here we have a chart that's a visual explanation of how the GIC is funded. As you can see in the dark blue, the largest piece of the GIC's funding comes directly from the Commonwealth through the state's budget. In addition to that, we have premium contributions made from our municipal partners. That's municipalities and regional school districts and a number of other entities shown in green. And the members yourselves, of course, through your premium payments drawn from your paychecks, and for retirees from your pension, are responsible for the share shown in purple. So noting from the previous slide that the Commonwealth contributes the majority of the GIC's funding, this slide explains a little bit about how that funding is put to work. I don't want to spend a lot of time here, but what I want to express here is that the GIC is a self-insured employer. So this means that it's the Commonwealth of Massachusetts that pays the employer share of medical claims, regardless of how much the Commonwealth has budgeted for those claims. So it's essentially the state that holds the insurance risk, not the health insurance plans and not our members. So if medical claims exceed what the state and we at the GIC have budgeted for any reason, it's the Commonwealth that pays those claims, and it doesn't impact the members. The three boxes at the bottom, just quickly, the three boxes at the bottom here explain how those claims are actually paid. So when you as a member receive your health care from a provider, that doctor or hospital sends a claim to the insurance carrier, one of our 6 insurance carriers that we noted. And then the carrier is essentially acting as an administrator for the GIC. They pay the provider for those services, and then they bill the GIC. And then we reimburse the carriers for those costs. So a little sense of how that works and what it means to be self-insured. So here, I just want to remind you that, and we'll do this a few times through the presentation very briefly, that you can submit questions through the Zoom Q&A function at any time. As I noted, we will pull some of those questions and address them verbally after the presentation. And please, if you have inquiries that involve personal information or personal health information, please use the contact form in the green box at the bottom so that we can maintain your privacy.
And Matt, before we move forward, I've noticed that there are quite a few questions coming in using the chat function. I just wanted to remind folks that we will not be answering questions in the chat function, because folks will be able to see, all attendees will be able to see our answers in the Q&A function. So that's why we won't be using the chat function. Please ask all of your questions using the Q&A function. Thanks.
Great. Thanks, Erica. So here we're going to move on to health insurance premium rate development. So on the next slide, you'll see this is our timeline that we use every year in developing our premium rates. As you can see, we had an initial discussion with our commission about preliminary rates at our December 16th meeting. That was followed last week when we presented the proposed plan design changes that I'll speak about in a moment. And both of those meetings are available on the GIC's YouTube page as well, if you're interested in reviewing those. So it's our next meeting on February 10th, where the commission will be voting on the proposed plan design changes, and then they will vote on our final premiums March 3rd in advance of the annual enrollment period. So that's the timeline that we work with. So I mentioned preliminary rates. Those were what we presented to our commission on December 16th, and it's what we will be presenting here today. That means the rates as they would be if we made no changes across the plans, that we made no changes to carriers, there was no change to our funding, and that the member enrollment across all of our plans remains the same. The expected aggregate increase is the average across all of our plans, both Medicare and non-Medicare. However, it's important to note that specific plans will have each their own specific change in rates, which may fall outside of the range of averages, the overall average range that we see noted here below. So this year, we expect an aggregate premium increase across all of our plans of about 5.8%. So next, we will review some important changes in the insurance market that affect GIC plan offerings and the plan design changes that we are proposing for the commission next week that I referenced, and that they'll be voting on February the 14th. So one of the GIC's health plans, Fallon Health, next slide, announced last year, many of you may have read about this, that they are exiting the commercial health insurance market to focus on their mass health line of business. So Fallon has been a longtime partner of the GIC, and we are sorry to see them go. I do want to make clear that this is a business decision made by Fallon Health, not by the GIC. But as a result of this decision, Fallon Select and Fallon Direct, those two products, will no longer be available to GIC members in this coming annual enrollment and for fiscal year 2023. So any of you that are currently enrolled in these Fallon plans must enroll in a new insurance product during the annual enrollment, which again will run from April 6th to May 4th. Members, this is really important to note for those in Fallon plans, that if you fail to actively take a step and enroll in a new plan, you will be default enrolled into the Unicare Plus plan. So what that will mean for some of you is, depending on the plan that you're in, it could be an increase or a decrease in your premium. If you are in the Fallon Select plan, you may see a decrease in your premium. But if you are in the Fallon Direct plan, you will see an increase of about $63 in your premium. So with that in mind, we really urge all of our members enrolled in Fallon plans to actively shop and enroll in new plans during this annual enrollment. Otherwise, you run the risk of being automatically enrolled into a plan that may not meet your needs. At the bottom of the slide here, we know that many members may have questions regarding the merger of Tufts Health Plan and Harvard Pilgrim Healthcare, what it means for your coverage. I do want to assure you that this merger will not impact GIC options in fiscal year 2023. Our Tufts and Harvard Pilgrim products will remain unchanged during the coming annual enrollment. So we do expect the new merged company, Point 32, to compete for GIC business during the upcoming procurement process for the following year. And that process will kick off a little later this spring. We'll say more about that in a moment. So let me say a word about our proposed plan design changes. For fiscal year 2023, we are in the 5th and final year of our current contracts with our current health plans, of course, except for Fallon, as I just mentioned. And as a reminder, we in general like to preserve the bulk of changes to plans for the procurement process and to only make minor adjustments in year-to-year plan designs. And that is especially true for this year, the last year of our current health plan contracts. So that said, we are proposing no changes to copays or deductibles, whether you're in an active or Medicare plan. We are proposing an expanded behavioral health benefit, a small but important change that will expand access to an important set of services for mental health treatment for children and adolescents. So I wanted to say a brief word about that. So at the GIC, we have made coverage for behavioral health a top-level strategic priority, and we acknowledge that the mental health needs of many young people are growing dramatically and need to be addressed. In 2019, the Commonwealth required most health insurance plans to expand coverage for a range of community and family-based mental health services for children and adolescents. But at the time, those rules did not apply to the GIC. Some of these services are already covered by GIC's carriers, but this, if adopted by the Commission at our February 10th meeting, will make sure that the coverage that we offer through our plans is identical to the coverages that are available to most members in private insurance plans. So these are services traditionally covered by Mass Health, but clearly are in more broad need in different insurance segments. So we want to do our part. So we've listed the services here below for your reference. So with that said, just another brief reminder that if you have questions, we will take them and answer them throughout the session in the Q&A function. Again, not the chat function, but the Q&A function. And we will take up some questions verbally at the end of the presentation. And again, remind you, please don't post or share any information about your personal situations so that we can protect your privacy. So now that we've reviewed what's upcoming for the annual enrollment this year, I want to switch gears a little bit and talk about the upcoming health benefit procurement. The GIC is required by law to procure new contracts, including our health insurance carriers and pharmacy benefit carriers, at least every 5 years. And as I said earlier, we're currently in year 4. We're heading into year 5 of the contract and have been working to prepare for this new procurement. So this slide is just a high-level timeline for the procurement road ahead for us. And the road behind us. In 2021, we focused on gaining feedback from stakeholders, including members. I'll have more to say about that in a moment, and developing our strategy for the procurement. Now, in 2022, we're moving forward to draft a request for responses from our health insurance plans. That's commonly called an RFR. But we will very much still be engaging with members and stakeholders throughout the process, and these sessions are an important part of that. So we plan to release the RFR in the spring of this year, likely in April, and review bids that have been submitted over the summer with the expectation that our commission will vote in late 2022, probably in October. So once the commission votes, staff will begin to negotiate and implement those new contracts, and this coverage will begin July 1st, 2023. So as I noted on the previous slide, we've been very busy engaging with members and with other stakeholders about this procurement. And we've had 3 main objectives in doing that. First, we want to make sure that we are clearly communicating our timeline for procurement and our priorities so that all stakeholders are aware that this is underway and where we're focusing our attention. I'll say more about that in a moment. Second, through our engagement meetings, we've learned and collected feedback. We will continue to do so that the RFR, when it's drafted, will ultimately lead to a successful procurement. And third, throughout the engagement process, we want to make sure that we're building confidence in the process itself and being responsive to stakeholders so that we can ultimately provide a recommendation and a path forward that meets your needs. So as I mentioned earlier, we've engaged with members in a variety of ways, including these sessions. But this summer, last summer, we released a survey, which produced some really excellent feedback to us. We had a very strong response from members. Nearly 100,000 members received the survey by email links, and we had a variety of other efforts to promote the survey. So we used a particular approach with the survey called conjoint analysis, which is a sophisticated research technique that helps us to understand what features of a product or service that our members want most. So in this case, health insurance. So for those of you who took the survey, you'll recall that it presents participants with often difficult choices and trade-offs between various features of a product, from cost sharing to access to hospitals and a variety of other features. So thank you all for taking the survey. As I said, it was extremely helpful to us and continues to be. So here we just note briefly some of the primary takeaways from that survey. Not surprisingly, the findings confirm much of what we've heard from members for a while. Our members are most sensitive on average to changes to out-of-pocket costs and deductibles. While it's important to note that the GIC's cost sharing is generally lower than much of other private insurance, most of our members live on modest public salaries and fixed income pensions. So increases in copays and deductibles can have a substantial impact. We've also heard that access to a range of hospitals and doctors is important to our members, and that generally our members are satisfied with the coverage that the GIC provides. However, I do want to note that below the overall average numbers, we also learned that younger members, especially, were more interested in options that might provide a lower premium, which oftentimes does include changes to cost sharing or broad access to providers. So there is some interest in some new and different options there. And so just thank you again for those of you who took the survey. It was not an easy one, but the feedback is truly appreciated. So we're getting there. I do want to say a few words here about how we're thinking about our health benefit procurement and describe the areas where we want to make progress so that we can deliver on our mission to you. First, I want to call out on the left-hand side of the slide, strategic areas of focus. Of course, top of that list is affordability. Across Massachusetts, health insurance premiums are rising faster than the economy is growing, certainly faster than wages and pensions of state and municipal public workers. As experts who track this data understand, health insurance premiums are rising largely because the prices charged by hospitals and doctors is rising. So we have the benefit of living in a state with some of the best healthcare in the world. But in order to provide coverage that is affordable, we really must address this long-standing and troublesome trend. In addition, we've witnessed some truly life-altering breakthroughs in prescription drugs over the last decade, but in many cases, those drugs come with staggeringly high prices. Again, here, our goal is to find the right balance that provides you, our members, access to these important therapies, but at a cost that our members and taxpayers can afford. So second here, health equity. Of course, COVID-19 has laid bare inequities in the healthcare system that have been around for a very long time. And we understand that not all communities have the same access to high quality, affordable care. The GIC is committed to doing its part to close those gaps and provide more fairness and equity to all of our members. Third, behavioral health. As we all know, The need for mental health and substance use disorder services is rising, and in many cases, access to these services is not available when it's needed most. I can assure you that the GIC will do all that it can to see that these services are expanded and modernized so that we can close these gaps as well. It is important to note that, as you see in the center part of this slide, that these strategic areas of focus are not unrelated silos, but instead are all interconnected. So addressing the rising pressures of affordability is not a central focus of our strategy as an objective unto itself. We focus on affordability because a failure to do so has a number of important implications. It hinders us at the GIC from providing affordable quality insurance to you. It also keeps you, our members, from spending your hard-earned income on other things that are important to you. This is especially important, of course, for those of our members at the lower end of the wage scale. But it also makes it more difficult for us to make progress on other important goals that I've already mentioned: behavioral health, health equity. I'd also note the importance of primary care. Our ability to address these issues really is undermined by the ongoing affordability challenges that we faced. And then I'd say lastly, it increases the financial burden on the taxpayer and the state budget. So in addition to being our members at the GIC, you are all, to the degree that you're still living in Massachusetts, taxpayers in the Commonwealth. So that is all of us that live here, including you. And it makes it more difficult. The rising pressures of affordability make it more difficult for our elected leaders to address and invest in other areas that are really important: education, transportation, and a number of others. So I won't speak to the guiding principles. You can see how we've translated those strategic areas of focus and the way we think about them as interconnected into the drafting of the actual RFR. So before I turn it over to Paul Murphy for the next portion of the presentation, just one quick reminder again: if you've joined the session late, you may submit questions during this session in the Zoom Q&A function at any time, and we will respond to those. And we will be pulling out some questions that have a broader interest during the verbal portion of the Q&A. And again, if you have a question of a personal nature, please be sure to use the contact form in the purple box so that we can maintain your privacy. So at this point, I want to turn the presentation over to my colleague, Paul Murphy. Paul is our Director of Operations and someone who has been with the GIC for over 3 decades. He is a wealth of knowledge, and we are very lucky to have him on Team GIC. So Paul, please go ahead.
Thank you, Matt, and good afternoon, everybody. As Matt mentioned earlier in the presentation, we thought we would give a brief overview of retirement for those employees that are thinking of retiring, and all of their questions about Medicare and some of the more frequent questions we get throughout the year for retirees. So we thought we would incorporate this into these listening sessions to help members navigate the system when they're thinking about retiring. The first area, some general information. GIC encourages anyone that is thinking from retiring from state or municipal service that they notify their agency at least 30 to 60 days in advance of their retirement to avoid any disruption in their coverage. The GIC does require an application for retirement to be sent to GIC so that we can move you into a retirement status when you file your retirement. So it is extremely important that you notify your agency to avoid any loss of coverage that the agency may accidentally terminate you, not knowing that you retired. For state employees, once you file the retirement form with GIC, FYI, we will bill you roughly 3 to 4 months following your retirement date for all of your GIC coverage. Since you no longer are working for the Commonwealth, it's impossible to have deductions, and it may take 3 to 4 months for having your pension check processed by the retirement board. During that gap, we need to bill you. So I encourage everyone that when you receive a bill during that interim period, that you pay the premium for the GIC coverage to avoid any disruption of coverage. Once GIC receives information from the retirement board that you will be collecting a pension check, we will coordinate a deduction from that retirement check and stop the monthly billing. Life insurance. Life insurance, there are 2 policies that the Commonwealth offers. One is called the basic life insurance policy and the amount of $5,000. If you have health insurance with the Commonwealth or just the basic life policy, that $5,000 policy continues into retirement as a retiree. So you can take that policy with you into retirement. The other policy that GIC offers is referred to as supplemental insurance or optional life insurance. And this is one area we encourage employees to look at the cost of the optional or supplemental life insurance if you are enrolled, to look at the cost of that, because as a retiree, the premiums for that coverage increase once you retire. Up until age 70, there is a retirement rate, but thereafter, after age 70 and every 5 years thereafter, that supplemental or optional life insurance policy does increase with age. So we encourage people to look at the optional amount life insurance that they have on file. And by all means, you are welcome to continue that and pay for those premiums, but it does get expensive after age 70, in that we encourage people to look at that to make sure that they want to continue that into retirement. It is strictly a term policy. There's no cash surrender value. So once you end the coverage, coverage is over. You can cancel or decrease your amount of optional life insurance after retirement. So many people think that if they want to keep their optional life insurance, say till age 70, you can do so, and you can cancel or decrease that coverage anytime throughout the year. GIC will also notify all retirees when their premium is due to increase at age 70, 75, 80, and all the way up to age 100. We will send a letter to the retiree stating what the new premium will be, and within that letter, the retiree can return the option of canceling or decreasing the coverage. But it's extremely important. We get a lot of concern from retirees when they open the bill that their optional life insurance premium is so expensive, and then they want to do something when they receive the bill. So you can do that, but we encourage you to look at that premium before you file your retirement papers. Dental insurance. This is one area where we find members get confused. There are many different dental plans that are offered through the Commonwealth. There is a GIC manager dental plan that we offer to all employees who are not part of collective bargaining. And the unions in the Commonwealth also offer a dental and vision plan directly through the union. This is one place where you should do some homework. As a retiree of the Commonwealth, you may continue your GIC manager's dental coverage through COBRA, or you may be able to continue your union dental benefits through COBRA. You have to make that choice whether you want to continue. Most of the COBRA premiums are at 100% premium. For GIC's plan, it ranges anywhere from $38 a month to about $138 to continue that coverage under the COBRA option. The third option GIC offers is a retiree dental plan. You can sign up for the retiree dental plan at retirement, and you can enroll. The one thing we would like to remind everyone is that the benefits between the GIC retiree dental plan and the COBRA plan that you may continue through your union or GIC are very different. So we encourage you to look at the benefits offered by both. GIC's dental vision plan and the retiree dental plan are administered directly with MetLife, and we have information on those benefits on our website. If you want to continue your dental benefits through the union, we encourage you to contact your union and set up the process to continue that benefit through the COBRA directly with the union. One thing to note about the retiree dental plan that GIC offers is that if you want to enroll in that plan, the cost is $30 a month for an individual plan and roughly $68 for a family plan. So the cost of that plan is less than the COBRA option. You do not have to enroll in the dental plan when you retire. You can continue through the COBRA, not take COBRA, or you can sign up for the retiree dental plan or not sign up for the retiree dental plan at retirement. You may enroll in the GIC retiree dental plan any annual enrollment thereafter once you retire. So if you want to hold off and not enroll in the dental plan, you have a right to do so, and you can pick it up during any annual enrollment period thereafter once you retire. One word of caution that if you do sign up for the GIC retiree dental plan and you decide that you want to cancel that policy or you don't like that policy, once you cancel that policy, you are locked out. You can never get that policy back once you cancel the policy. Health insurance. Now, this is one area where it comes into play with people that are under 65, members that are over 65, and what to do with their coverage. As a state employee, if you were hired before July 1st, 2003, your current contribution for health insurance is at a 20% contribution. If you were hired in the Commonwealth after July 1st, 2003, your contribution for your health insurance is currently 25%. All retirees of the Commonwealth pay 20%. So those of you that are paying the 20% contribution, the same premium continue into retirement. For those of you that are paying the 25%, it will drop down to 20% for your health insurance. If you are under age 65 when you retire, you are allowed to keep the current non-Medicare plan that you had at retirement up until the age of 65. So there is no change. You can remain in your current plan. If you want to change your plan at retirement, you can do so. Retirement is a qualifying event for you to change your plan, change your coverage, enroll in GIC benefits, or drop your GIC benefits at retirement. Over age 65. One part to note is Medicare comes into play at age 65. There is a state law that requires all state employees and municipal employees, when you retire, if you are age 65 or older, and you are eligible for Medicare, state law requires you to enroll in Medicare so that you can continue your GIC benefits. Medicare has three parts. Medicare Part A, it's referred to as hospital insurance. That is free. There is no charge to you as a retiree. Medicare Part B is medical insurance. There is a charge of $170 per month to continue the Medicare Part B coverage. And then there is a third part referred to as Medicare Part D, which is prescription drug coverage. As a retiree of the Commonwealth, you do not need to sign up for the Part D prescription drug coverage. All of the plans GIC offers has sufficient pharmacy coverage for you to continue once you retire. You do not need to enroll in Part D. Medicare Part A and Part B is required if you are eligible. Only Social Security can tell you if you are eligible for Medicare Part A and Part B. Like I said, if you are eligible, state law requires you to join one of our supplemental plans. The reason is that Medicare Part A and Medicare Part B don't cover all of your medical needs once you retire. When Medicare leaves off on paying your bills, you need a supplemental insurance. GIC offers many different Medicare supplemental plans. And what we offer supplements to where Medicare leaves off. So when Medicare pays the bill, they balance, your Medicare plan with GIC will pick up the balance. So our plans just supplement the Medicare Part A and Part B coverage. But if you are eligible, state law requires you to enroll in the Medicare Part A and Part B. For those of you that are younger than age 65 at retirement, 3 months before your 65th birthday, you will receive a letter from GIC with instructions on how to elect a Medicare supplemental plan with GIC. So we contact all of the retirees as well as any spouse that is age 65 or older that they need to enroll in Medicare, and we give you the options in the letter for the different plans that you may want to enroll in. If there is a state employee who is not eligible for Medicare Part A or Part B, say they worked for the Commonwealth or the municipality all of their life, GIC will still require you to enroll with Medicare and get denied. Medicare will just simply say that you are not eligible. If that is the case, then you as a state retiree and your family can continue with GIC in a non-Medicare plan. So your coverage continues and you don't have to enroll in a Medicare plan. A couple of things to note is that, like I said, all of the pharmacy Part D, you do not need to enroll. That is covered under all of your Medicare supplement plans that GIC offers. One question we do get from our members is that if you continue working after age 65 for the Commonwealth or a municipality, you do not need to enroll in Medicare Part B. You can enroll in Medicare Part A, but we encourage you to defer enrollment in Medicare Part B. The reason is that while you are working for the Commonwealth after age 65, your Commonwealth insurance is primary. So there is no need to enroll in Medicare. If you are retired, it is required, but not if you remain working for the Commonwealth or municipality after age 65. Enroll in Part A and defer the Part B. There will not be any penalty from Social Security for deferring your Medicare coverage. Once you decide to retire after age 65, you will have 7 months from your retirement date to go back to Social Security and enroll in the Medicare Part B coverage with no penalty. I know there's a lot of information and we're trying to touch on some important pieces and questions that we get every day. Our website, mass.gov/GIC, has information and a video on what to expect when you turn age 65 and all of our Medicare supplemental plans. And we also have a section on frequent questions when you retire. Some things to keep in mind is that when you retire from the Commonwealth, you will have the opportunity to participate in every annual enrollment period thereafter. You can change your plans, you can drop plans, you can enroll in the dental, you can cancel your dental. If you have qualifying events such as birth, marriage, divorce, those qualifying events allow you to make the changes as a retiree. So there's a lot of information that I'm trying to give you in a short period of time. You know, if you have questions, the Q&A section, you feel free to ask your question there or fill out the GIC online form that's on our website, and one of our staff will get back to you with the answer. So Matt, that's all I have right now. I know it's a lot and a lot of fast talking, but I'll turn it back over to you.
Great. Thank you, Paul, for that. So before we transition to the Q&A, I think we have a few reminders and resources that we want to share with you. I'd like to take a quick moment to promote a new tool that the GIC has been rolling out called My GIC Link. So this is our online member portal. It's our online member portal that over time we hope will replace all paper forms that the GIC has used for decades. Through My GIC Link, members can enroll in coverage, can view their current benefits, and make all kinds of changes that in the past, again, had to be mailed into the GIC. All active state and municipal employees with a valid email address have access to My GIC Link as of this past November, and we will be rolling it out to retirees in the fall of this year. And I encourage you to provide your preferred email address to receive communications about the portal. There will be more information about how to register when benefit statements arrive in your mailboxes in February, so keep an eye out for those. And finally, just want to again remind you of the dates of the annual enrollment. Opens on April 6th and closes on May the 4th. So with that, we've got a little bit of time left here at the end to transition to the kind of Q&A. We've been keeping an eye on the questions, and we'll keep this slide up about additional resources for you to reference. But with that, I think I'll turn it back to Erica and see what questions we want to address verbally to the whole group.
Thanks, Matt. I think one of the questions that we've seen pop up is regarding COVID test reimbursements. And so if you could just speak to that. Thank you.
Sure. So first of all, I would direct all of our members to our website. We've got lots of information there about coverage for COVID rapid tests. Members may be aware that the federal government recently released rules requiring plans to cover them. So we do cover COVID rapid tests. The guidance was a unique federal guidance, gave us very little time to implement the changes necessary. So we are working feverishly on this. I will say for the moment, we are focusing on an approach where a member can purchase a COVID rapid test, keep your receipt, and submit it to your pharmacy benefit manager for reimbursement. We will soon be replacing that with a much simpler approach where simply with your pharmacy ID card, you can walk into the pharmacy and not have to pay anything out of your pocket to be reimbursed. I will note that as I'm sure everyone knows that, these things are, while they are covered, they are still extremely hard to get your hands on. So that will have to catch up to the demand, but you should know that there is coverage for these, and our approach to it is going to evolve over the next few weeks. So please keep an eye on the GIC website for more information about that.
Thanks, Matt. So a couple questions coming in here. Is there any thought to offering insurance coverage for +1 instead of just individual and/or family coverage?
Yes, there is some thought being given to that. There has been for a number of years before I got here even. As just by way of background, we offer 2 different plan types today, individual and family coverage. And the question is whether we would contemplate adding a different category, which is the individual plus 1 other individual. As with all things of this type, what an approach like that would mean is that there may be less expensive coverage in an individual +1 plan, but any reductions there would be likely have to be made up in the other plans. So this is often a case of sort of deciding winners and losers. So we have to balance all of those competing interests. But I will say that it is under consideration, and those are the sorts of things that we will review as part of the coming procurement. So thank you for the question.
Thanks, Matt. Let's see here. Will members be able to use, sorry, just jumped on me here. Hang on one second. Will members be able to use the GIC portal for this annual enrollment to make changes, that is? And I think I can turn that over to Paul.
Sure. The new member benefit portal that we rolled out last summer is available to all active state employees and all active municipal employees. And if the person has registered and signed up for the member benefits portal, they will be able to make annual enrollment health plan changes in the portal this year during annual enrollment. It's not available to retirees yet. That is coming hopefully later this fall, but active employees can make the changes in the portal.
Along those lines, Paul, how can a person who signed up by paper enrollment gain access to the portal?
You can visit our website and you'll see there's a information on the My GIC Link member benefits portal. Also this year, with the benefit statements that we send out, we'll be mailing them to all of our members in mid-February. On the back of that benefit statement, we've included instructions this year on how to register and sign up for the member benefit portal.
Thank you. I've got another one for you. Just one second. Our staff is so fast at answering questions live that I keep losing them in the chat. Let's see. So this question is, if an individual is on their spouse's insurance, when do they need to switch over to GIC if they plan to retire in the next few months?
If you are covered under your spouse in another plan outside of the Commonwealth, when you retire from the Commonwealth, retirement is a qualifying event. So once you decide on the day you want to retire, that is the date that it's a qualifying event for you to then enroll in GIC benefits. So retirement is a qualifying event for you to come on to the GIC plan.
I've got another one for you, Paul. Regarding retirement and mandatory Medicare, what if the retiree is 65 or over? And that question just jumped. 1 second.
It's most likely that what if the retiree is age 65 or older and they have a spouse who is under age 65?
I'll go back and find it. You can answer that question right now.
The way it works is if you are retired, whether it be you as the member or your spouse, when they reach age 65, it is required that they enroll in Medicare Part A and Part B. So whoever reaches age 65 first is required to enroll in Medicare Part A and Part B. At that time, you or your spouse can choose a Medicare plan. If your spouse is under age 65, your spouse will remain in the non-Medicare plan. So we treat it as what we call an over and an under. You as the member or spouse that are age 65 stay in the Medicare plan, and any spouse under age 65 remains in the non-Medicare plan. There's no disruption in coverage.
Thank you. Moving back here, we have a question that I think is for Matt, and that's around high deductible health plans and the potential for offering those going forward.
Yeah, thank you for that inquiry. And I would say that that's the sort of decision that we would make through the procurement process. Those types of different types of plans that we have not traditionally offered would be something that we would evaluate as part of that process. I can say that we are evaluating that. I will say, kind of refer the questioner back to the survey results, which I think tell us two things. One is that there's broadly a great sensitivity to changes in deductibles. So a higher deductible health plan would, I think in general for our membership, not be broadly, have broad interest. That said, I did note that some of our younger members have expressed an interest in making some trade-offs of this variety that other members are not. So I think those are important things for us to take away, but it is an option that we evaluate, and we will make some decisions about that during the coming procurement.
Sorry, struggled to take myself off mute there for a second. We did get a few questions regarding HSAs and how those work or don't work with the GIC. So if Matt or Cameron, you could take a stab at answering those, that would be helpful.
Yeah, I'll defer to Cameron for a quick overview there. It is a benefit that we offer. It's an important benefit to a fairly small number of our members. I would say a small percentage of our members, but I myself do have it, and I find that it is really helpful for managing the out-of-pocket expenses. in a plan. But Cameron, you want to say a few words about the FSA?
Sure. Just please, I was finishing up an answer on the Q&A, so I missed the start of the question. What specifically are we addressing?
Sure. This was actually about HSAs, not FSA,
Okay.
and how they work or don't work for the GIC.
Sure. Yeah, there's a very large difference between an HSA and a health savings account and an FSA. The GIC offers two flexible spending accounts through our vendor benefit strategies. One is referred to as the HCSA, that stands for Healthcare Savings Account. Now, that sounds confusingly similar to an HSA, which is a health savings account. But the medical FSA, the HCSA, that is to be used for qualifying medical expenses, such as anything that goes towards your copay, prescriptions, a lot of over-the-counter personal medical items nowadays as a result of recent legislation. And the federal government also increased the annual contribution limit for the medical FSA from $2,750, and it will be increasing for FY 23 to $2,850. The maximum contribution for the other FSA option, it remains at $5,000, and that is for dependent care expenses. That means childcare, or if you have a qualifying disabled dependent that you care for, those expenses can also be used for those costs, or that fund can also be used for those costs. Now, the difference between the medical FSA and an HSA, a health savings account, is that an HSA can only be used in tandem with a specific kind of medical insurance plan. And one of the things that differentiates those plans is they, first of all, have to have a significantly higher deductible than any of the plans that the GIC has traditionally offered. Plus, there is no upfront discounts on those plans. They're what's known as a first dollar cost plan design, and that is a legal mandate. So if you go to the doctor, you don't pay a $20 copay, you have to pay whatever the contracted rate is for that office visit, which may be $80, $100, $200. Also, if you fill a prescription, you don't pay a copay, you have to pay whatever the contracted rate is for that medication. So if you are on, a medication like Humira, which many of our membership are, the monthly costs for that medication tend to run somewhere around $2,500, $3,000. So that is a big drawback to these HSA compatible plan designs.
So let me just say a thank you, Cameron, for that very clear explanation of the differences here. My apologies for answering the wrong question initially. As it relates to HSAs, I guess I would refer back to my prior comments about the high deductible health plans. I mean, this is because they go together hand in glove. You can't have one really without the other. So that is the sort of option for our members that we would evaluate as part of the upcoming procurement.
Thanks, Matt. So we've got another question regarding when benefit decision guides will be available. And so I'd like to turn that question over to Paul.
Yes, the benefit decision guides for this year will be published on our website at the end of March, beginning of April. And we will be mailing a benefit decision guide to all of the retirees home starting at the end of March. So you will have the information in hand at the start of annual enrollment, but they won't be ready until the end of March, beginning of April.
Great. We've got a question here wondering if there are any plans that cover acupuncture. That's coming up twice, I think. And I'm not sure if anyone knows that off the top of their head. But if either Cameron or Janine could take a look through their mental dictionaries, I guess, and see if one of them covers acupuncture.
I know that, oh, sorry, Janine, go ahead.
There you go.
I was going to say, we know that acupuncture is covered under the Tufts Medicare Complement Plan, but we would need to double check to see if it's covered by any of the other plans. That's not what would ordinarily be considered a mainline benefit, and rather than provide incorrect information, we'd rather get back to you on that.
Great. So you would suggest then that individual who is interested fill out the contact form?
Yes, you do that, or you can reach out directly to your medical insurance to your current medical insurance carrier and ask if they cover it. I know that some plans do, some plans don't. It's not something that we mandate at this point in time. So it's been a matter of whether or not those individual carriers cover them for their population as a matter of course.
Great, thank you, Cameron. And let's see, we have another question on COVID-19 tests. Not sure that in terms of our policy that what we know right now that we'll be able to answer it, but I will ask it. On COVID-19 home tests, will purchases made prior to January 15th be reimbursable with receipts? And after tests become available at preferred pharmacies at no out-of-pocket costs, will a reimbursement option still be available if they're out of stock at CVS or a preferred pharmacy?
I think the first part of the question is defer to Andrew about whether reimbursement is permitted for tests purchased before that date. I believe the answer is no.
Reimbursements will be available going back to January 15th. And to the second part, you will be able to get reimbursement if there are no tests available. They will be capped at $12 or the cost of the test. There is a mandate in the law that if the provider cannot, if there are no tests available through the channels that we've put up, then you will get reimbursed in full.
So this, again, I would reiterate here what I said earlier. This is an evolving issue. And we want to be able to communicate what we know when we know it, and we will use our website as the resource there to direct you. So please keep an eye on the website.
Great. Let's see. Cameron, I know when we did our session yesterday, there were a couple of retirement-based questions that folks had asked. I was just wondering if there was anything else you might think that we'd want to cover today, questions that came up yesterday.
Are you referring to me, Erica?
Either, well, Cameron had been monitoring questions yesterday. That's why I asked him. Okay. Or if there are some things that have popped up that you think are important to cover.
I mean, there's a couple of areas I would stress that, again, GIC does bill you when you leave employment until you get your pension. It's important to pay the bill. Many retirees think that because they're going to get a pension at a later date that will go retroactive, the GIC premiums are deducted from that, and that is not true. When you receive your first pension check, you will not have a deduction, but going forward after that check, GIC will coordinate the deduction. But during that gap, from the time you leave till you get that first pension, you need to pay the GIC premiums. There's a lot of confusion around Medicare. The simple thing to remember about Medicare is that if you are retired and you have health with GIC, you as the member at age 65 or any family member, particularly a spouse at age 65, must apply for Medicare Part A and Part B with Social Security. If you are eligible, then you have to join one of GIC's Medicare plans. If you are not eligible, you do not have to join a Medicare plan and you stay in the plan you have. If you're going to continue working after age 65 for the Commonwealth or municipality, you only need to enroll in Medicare Part A. You do not need to enroll in Part B because that will be at a later date. You'll be able to enroll in Part B once you decide to retire after age 65. A lot of people think that there are penalties if they don't enroll at age 65. That is only true is if when you are retired and you turn 65 and you don't take the benefit at age 65. But if you're going to continue working after age 65, you can defer the Medicare without a penalty. Those are some of the big areas where we get a lot of questions from our members.
Great. Thank you, Paul. Seeing no further questions, I do see actually one that just popped up about where an individual can find a list of carriers and plans to choose from that doesn't include Fallon. So I would just look to the answered questions that are already there. Or Donna, if you wanted to jump in and let folks know where that list might be. Oh, actually, I see the answer right here. I'll just go ahead and say it. Once the the year 2023 benefit decision guides are finalized, the resources on the GIC's website will be updated. So you can keep an eye out for that. Thanks, Cameron, for rescuing me on that one. Let's see. We did have a couple of other questions come in. Do you enroll in Medicare when you turn 65 or during open enrollment when you are 64 and will be turning 65 during the coverage year?
You enroll in Medicare, like I said before, if you are retired and turning age 65. You enroll at age 65. You do not enroll in Medicare during annual enrollment. Annual enrollment has to do with your health plan with the Commonwealth. Your Medicare is directly with Social Security. Social Security has a rule that you may enroll in Medicare A and B 3 months before your 65th birthday, the month of your 65th birthday, or 3 months after your 65th birthday. So don't mix that up with our annual enrollment. You must enroll in Medicare A and B when you turn age 65. Annual enrollment applies to if you want to change or make changes to your Medicare supplemental plan that you have with GIC.
Great. Okay, just looking at the time here, we're about 10 minutes over. If your question wasn't answered in the Q&A function or live, we will be pulling together a series of frequently asked questions that we'll be posting at a later date when sessions close. So I'll turn it back over to Matt now.
Sorry, I had myself on mute. Thank you, Erica, and thank you all. As we wrap up, I just want to take a moment to thank everybody, thank my staff for participating, and thank you for your engagement and your feedback.